What is breast cancer? Well, perhaps I can take that back a little bit further and say, what is cancer and how does a cancer cell develop? Now, normally the cells in your body, and there are trillions of cells in your body, they divide and change into liver cells or heart cells or muscle cells, and they're controlled by their genes and they're controlled by the cells around them. So they're well controlled, they divide in a well-regulated way, and eventually they will die. And you may have heard of this process called apoptosis, which is regulated cell death. So all of your cells are mortal, they all divide a number of times and then they die. And there are all these signals that interact from the cell itself and from the cells around it that control it and make it behave in an orderly way. Now, when a cell becomes cancerous, this disorder is upset. And the first thing is that the cell will continue to grow even when the signals that tell it to grow are not present. So if you like, it always feels it's being told to grow, even if it's not. So it carries on growing. And the other thing it does is it doesn't respond to the signals from cells around it that tell it to stop growing. And it will bypass that regulation. So it becomes a disordered growth. Now, as it grows, it does other things. So, for example, it encourages blood vessels to grow into this ball of cells that are becoming a cancer because it needs nutrients. So it does that too. And the other important thing it does, it somehow manages to stop your normal immune system from recognizing it because it becomes a different cell. It becomes an alien cell, if you like. And normally, abnormal cells are picked up by the immune system, be it bacteria or, for example, in people who have transplants that don't match. It's recognized as foreign and the immune system will destroy it. And somehow a cancer cell stops the immune system doing that, but also it can fool the immune system into protecting it. So it becomes something that the body tries to nurture rather than reject. And somehow deep down in the cell, there are these genetic changes. Now, you're familiar with the fact we have DNA and it's made up of a 4-letter code, and there are 3 billion of these, as what we call base pairs, that make up our DNA. And some of these change somehow, and we're not quite sure what makes them change or how they change, but the cells build up these genetic abnormalities and the chromosomes become abnormal, and this is all passed on as the cell divides. And the other thing a cancer cell can do, it can grow using nutrients that normal cells don't. So it can grow faster and quicker than normal cells. And this allows it not only to keep growing, but also bits of the cell to break off and spread perhaps through the blood vessels to other parts of the body. And we call this a metastasis. So for example, breast cancer, if it spreads, and I would say most of the time when I see breast cancer patients, it hasn't spread. But if it spreads, it would classically go to the bones or to the liver or to the lungs or to the brain. Those are the sites that breast cancer cells can spread to. And that's a characteristic of cancer. And sometimes you'll hear it called invasive cancer, but all cancers have this ability to invade. Now, in terms of breast cancer, there are some precancerous stages that we can recognize. And you might sometimes hear about things called hyperplasia. Now, these are normal cells that are slightly more active than usual. They're still properly controlled, so they don't spread and they're not cancerous. But sometimes these can lead on to other sorts of cells called dysplastic cells, which are beginning to look slightly abnormal. And then in breast diseases, we have a condition called ductal carcinoma in situ. You might see this as DCIS. And there are 3, if you like, flavors of DCIS. There's a high-grade DCIS, which we believe will become a cancer if it's left alone. So precancerous change, DCIS, does not spread. It doesn't have the ability to metastasize. So if we find this in the breast, we can remove it and prevent a breast cancer forming. The other 2 flavors, if you like, there's intermediate grade DCIS, which will probably become cancerous, but over a much longer period, whereas high grade DCIS may change within 5 years. The intermediate DCIS may take 10 to 15 years. And the third flavor is the low grade DCIS, which actually may never change. And whereas 20 years ago, we used to remove all of these with an operation, we will sometimes now leave the low-grade ones behind and just keep a very careful watch. So there is this spectrum of change within the breast cells that we can recognize through being slightly overactive, becoming abnormal looking, becoming precancerous, and then losing all the inhibitions that cells normally have to become invasive cancer that potentially can spread. How is breast cancer diagnosed? Now, there are two broad ways we find a breast cancer. The first way is through breast screening. Now, this looks at ladies who are completely well, have no symptoms in their breast, but in the UK are called every 3 years between the age of 50 and 70 to have breast x-rays, mammograms. And these can pick up small early breast cancers that you can't feel. They can also pick up the precancerous changes, the ductal carcinoma in situ, which will turn up as what we call microcalcifications in the breast. Now, having said that, most microcalcifications are not precancerous, they're age-related changes. But there's a specific sort that mammograms can pick up. So that's the first way you can find a cancer in a woman who is not aware she's got it, but it's picked up on a screening mammogram. The second way is when a lady finds a problem with the breast herself and goes see her GP and gets referred to a breast clinic to see a breast specialist. And the most common symptom ladies get is they find a lump. Now, again, an important thing to say is that most lumps I see are not breast cancers. They're things like breast cysts. They're harmless lumps like fibroadenomas. So most lumps are not breast cancers, but most breast cancers we see in the symptomatic clinic, as this is called, will be lumps. Now, there are other things to look out for that ladies are warned about, and it's changes in the size and shape of the breast. But again, this is very common as you get towards the menopause. Nipple discharge, again, is something ladies are told to look out for, but this is also quite common and usually not due to cancer. So if these things occur and there isn't anything else to find, it's usually fine, but what will happen is when a lady comes along to a breast clinic, we will ask her about her symptoms, we will examine, and then she will have some mammograms and probably ultrasound scans as well by the radiologist. These are the X-ray specialists. And if we do find something, they will have a biopsy taken of an area in the clinic with local anaesthetic so it's numb. Then they come back to see us and we can go through exactly what's happened and what we think is going on. And then it takes a few days to fully analyse the biopsy before we get the result. Now, the same thing would happen in a screening clinic. If something is picked up on a mammogram in a screening clinic, the lady will get asked to come back and have further tests in the biopsy. And it's the biopsy really that tells us exactly what's going on. In terms of what treatments are used and which people get which treatment in which order, when you take a biopsy of a breast cancer, it will tell you quite a lot about the cancer that we've got. So first of all, it will confirm that it's a cancer, and it will tell you a thing called the grade. Now, the grade is a measure of how quickly it's come up, and that's all it is. When the pathologist looks down the microscope, and pathologists are doctors who analyze specimens, if they don't see many dividing cells, remember a cancer is a group of cells that's dividing abnormally quickly. If they don't see many dividing cells, they call it a grade 1, so relatively slow growing. If they see a lot, they call it grade 3, which is faster growing. If it's average, they call it grade 2. But that's all it means. Some people worry that a grade 3 cancer means it's aggressive or bad, and those are not terms I use because it doesn't mean that at all. It's just a measure of how quickly it comes up. So that's the grade and how quickly it's growing. Sometimes pathologists will call it a different type. Most breast cancers are called ductal cancers because they develop in the ducts of the breast. There's also another common type called lobular breast cancer, which develop in the lobules of the breast. And the breast is basically made up of ducts, which end up in lobules, which is where the milk would be made in a breastfeeding lady. There are other sorts you might hear of tubular cancers or mucinous cancers, but these are just descriptions. So we get the type and the grade, and then we'll analyze it to see whether it's sensitive to the estrogen hormone. And 2/3 of breast cancers are, and 1/3 aren't. We also analyze for the progesterone hormone. It's about the same there as well. And then we look for what's called the sensitivity to the Herceptin drug, and we call this HER2. Herceptin is a sort of chemotherapy, and it's one of these molecules that cancer cells turn on automatically, which makes them grow even though there's no stimulus. And Herceptin is a drug that will block off this abnormal stimulus. And about a third of cancers are sensitive to the Herceptin drug. And if you have a HER2 positive or sensitive to Herceptin cancer, you will almost certainly have chemotherapy. So that's how we help work out some of those things. We also measure a thing called the Ki-67, which is a sort of a molecular marker of how quickly the cancer is growing. It can be very low, 1%, it can be very high, 80%, and that often fits in with the grade. So you can get an idea from the biopsy who will need what treatment. If you have an estrogen receptor positive cancer, you will have an anti-estrogen tablet such as tamoxifen or letrozole. If you are HER2 positive, you will have chemotherapy with Herceptin. You may also hear about things called triple negative breast cancers, which is not sensitive to estrogen, progesterone, or Herceptin, and those ladies will also get chemotherapy. Now, I'm a breast surgeon, so I operate on people with breast cancer, and most ladies will need an operation at some point. But if we know from the biopsy that ladies are going to need chemotherapy, we will often do that first. And there are two reasons for that. One is it gets it out of the way because it's not particularly pleasant and it gets it done. And the second reason is you can watch it work, because if you can see the cancer on a mammogram or an ultrasound or even an MRI scan, you can watch it shrink as the chemotherapy works. So you know it's working, and very rarely the standard chemotherapy won't work and you can change it to a sort that does. It also means that a big lump will end up as a smaller lump, which means the operation will be less. So we can begin to work out in which order to do different treatments. Ladies who end up just having a lump removed will almost always have radiotherapy as well. Ladies who need the whole breast removed mastectomy usually won't need radiotherapy, but sometimes they do. And again, we can adjust the treatments people will need when the surgery is done and we get the full results. And then we work with the oncologists who deal with radiotherapy, tablets, chemotherapy, and so on. And one of the reasons that breast cancer treatment is now so much better than it was is because there is now a whole team of people involved. We're treating every single lady and we try and individualize the treatments as much as we can. Now, what happens when you finish all your breast cancer treatment? What we hope is that the breast cancer is gone, you've had it removed, you've had your radiotherapy or chemotherapy, and you're perhaps on your anti-hormone tablets, which some ladies will take for 5 years, some ladies for 10 years. And what happens then, you go into a phase of monitoring. You become, if you like, cancer-free, but we always keep an eye on everybody. Now, we know that most ladies we treat don't have trouble again, but a small number do. So what happens is you will see the oncologist, so the doctor who did the radiotherapy, chemotherapy, for example, and you will see me as a surgeon, and we'll alternate. So, for example, for the first couple of years, you might see me every 6 months and the oncologist every 6 months, but 3 months apart. So the first couple of years, you'll see somebody fairly regularly. That's so we can make sure everything settles down after the treatment. And we know that in some breast cancers, if they're going to come back, they tend to come back fairly soon. So we keep an eye more closely over the first couple of years. You will get regular ultrasound scans and mammograms every year. After 2 years, perhaps you see me once a year, the oncologist once a year, but 6 months apart. So you're seeing somebody every 6 months, and then perhaps after 5 years, it's just once a year. And it's to keep an eye on the breast where you had the breast cancer, but also to keep an eye on the other side, because there's a slightly higher risk of having a different cancer in the other side if you've had breast cancer in one. So we do keep a close eye. We also make sure that all ladies know how to get in touch with us should they find any problems, so we can arrange to see them as soon as we need to. Now, why does breast cancer sometimes come back? Now, that's a really interesting question. Now, again, I would reinforce that most ladies we treat never have trouble again, but some do, and it'd be wrong of me to pretend that that's not the case. And breast cancer can come back in 2 places. It can come back in the same breast. And this is why, for example, if you've had a lump removed, we will give radiotherapy to the breast, because this reduces the chance of something else happening in the breast. It sort of calms it down, if you like. But we always keep an eye on the other side, and you wonder whether if that breast is perhaps a little bit unstable more widely than we can detect, and over time another cell will go funny for the reasons we've discussed. The other place a breast cancer can come back is somewhere else in the body. And this is what happens when a cancer metastasizes. A cell will break off and settle in the bones or the liver or the lungs, and it will sit there, and it will grow, and it will cause symptoms and come back. Now, breast cancers probably don't come back, as it were. That cell by the knee, in the bones, or in the liver was probably there when it was diagnosed, but we have no test that can predict or pick up a single cell. But this is one of the reasons why all ladies will have a treatment that goes all around the body. So yes, you have your operation to remove the lump, you may have radiotherapy for the breast, but you'll also have anti-hormone treatment if you have an estrogen-sensitive cancer, or you may have chemotherapy if you have a Herceptin-positive cancer, or what we call a triple-negative breast cancer. The reason is those treatments go all around the body. So if you have that cell we cannot detect, it will, in the majority of cases, kill off that cell. But in some cases, it doesn't. And a small number of ladies, over time, and sometimes 10 or 20 years later, this cell from lying dormant will somehow switch on and grow and cause symptoms that we can detect with other scans. But it's not so much that it's come back, it was always there, and we just haven't been able to detect it and get rid of it. But in most ladies, again, I'll emphasize, in most ladies, nothing happens.